So today I'm going to talk to you about GLP-1 shortages. My name's Hannah Bieber. I'm a consultant pharmacist for diabetes in Leeds Health and Care Partnership. So just a bit of background, as you're probably aware by now, we've got an ongoing national shortage of GLP-1 agonists. So these are used in the management of type 2 diabetes. This problem is not expected now to resolve until midway through 2024, and actually some of the information that we're now getting suggests that this actually may even extend beyond that for some of the products that we have on the market. So the supplies of the GLP-1 preparations, they may be intermittent, and this is where really we have some challenges to overcome. And also they may also be exhausted during this time, and it's being monitored really closely. So although other GLP-1 therapies may be available, it's possible that there will be insufficient additional capacity to accommodate switching everybody to alternative brands. So really we're suggesting that we don't do that at this time. So what products are affected? So just to remind you, what are the GLP-1 therapies? So we've got semaglutide, which is Ozempic, the brand name, and also Rybelsus, which is the oral tablet of the GLP-1, dulaglutide and liraglutide, all affected, and exenatide as well. And there's no uplift with any of those available. So really no chance to really switch people across at all. So where can you find up-to-date information on stock? So the SPS do have a medicine supply tool. I believe that this is not the easiest tool to use. So what I would suggest is get to know your community pharmacist really well, because they know this tool inside and out. And this is something where they can check what the supply issues are at the time. Who do we expect to be involved in the managing of this shortage? So prescribers in all care settings are likely to need to get involved at this point, and the NHS diabetologists and endocrinologists will also be supporting decision making around this if needs be, and also specialist diabetes services and associated healthcare professionals. So we expect really our most impacted service might be Leeds Community Healthcare at this time. People obviously living with type 2 diabetes and their families and carers may be impacted and trying to manage the shortages, particularly if there's intermittent supply of the GLP-1 that they normally take. And organisations commissioning NHS services are working really hard behind the scenes to come up with solutions for supply, and also horizon scan some of the products that might be coming on the horizon to help us out of this period of austerity around this particular drug. And also providers of NHS services. So how else can we support or upskill people so that we can make sure that people get switched on to other alternative therapies as needed? So what does the Department of Health and Social Care say? So they're really giving some key messages, and this is really what I want to focus on today. So the GLP-1s should be prescribed only for their licensed indication. So now's the time to review, is somebody on the GLP-1 for the right reasons, and avoid anybody who's not, to take them off of those drugs at this time. We want to avoid initiating people with type 2 diabetes on GLP-1 receptor agonists for the duration of the GLP-1 national shortage. That's because there isn't any uplift with these products, as I've already said. So starting more people on these therapies will mean those that are already established on these therapies may be also unable to continue with them. We need to review the need for prescribing a GLP-1 and stop treatment if they're no longer required. So, for example, they're not meeting the NICE criteria that was set out in the Clinical Guidance 28. We want to avoid switching between brands, including injectable and oral therapies. And where a higher dose of preparation of the GLP-1 is not available, we do not substitute with doubling up of the dose. A, this isn't a licensed thing to do, and B, it's not something that would be advocated due to excessive costs, and also just acceptability for the patient to be injecting themselves multiple times. Where GLP-1 therapy is not available, we would actually say to try to proactively identify patients established on affected preparations and prioritise them based on the criteria that we'll go through in a minute. And where an alternative glucose lowering therapy needs to be considered, use the principles of shared decision making, using the NICE guidelines in conjunction with the supporting information that's been given in the national guidance around this shortage. And where there's a reduced access to GLP-1 receptor agonists, we want to support people with type 2 diabetes to access to structured education and also weight management programs where available, also remission programs, and we'll come back to that in a minute. And order your stocks sensibly. Obviously, encourage people to not stockpile things, and to encourage also pharmacies to not stockpile things, or also for everybody to be singing from the same hymn sheet here around what our bottom line is. And these are really sort of your things that we really want you to stick to, so that we can make sure that we can maintain supply for those who are already on GLP-1s where possible. Prioritization for clinical review. In most cases, there will be a need to consider potentially alternative glucose lowering therapies, and we'd ask you to revisit with that where possible. There's nothing wrong with going back and revisiting with things like the SGLT2s. Some people they might not have been available when they got started on some of their other therapies, and so revisiting with some of the newer agents that are available that also may give weight loss and cardiovascular protection is always really helpful. And also you might want to just consider other alternative oral therapies as well if people aren't at a point where they can go onto insulin or want to go onto insulin, and that again comes back to that shared decision making. So should a particular preparation of GLP-1s be unavailable, and an alternative can't be sourced, what we would say is we try to ask clinical teams to proactively establish which patients need to be reviewed first. And those who are most at risk are going to be those with really high HbA1cs, over 86 millimoles per mole in the previous 3 to 6 months, or prior to starting a GLP-1, because obviously if you started a GLP-1, you got a really good response, and that might have come down, but obviously if you're going to stop the GLP-1, you're going to go back to where you started likelihood. So it's kind of looking back and understanding the timeline and doing that real investigatory process, which I appreciate takes time. HbA1c also, if it's not been recorded, so if you're in the dark on what you're doing. Also, if somebody has urine albumin creatinine ratio of greater than 30 milligrams per millimole, this would be GLP-1s give some protection to the renal system, and so actually removing that GLP-1 then may worsen their renal function. And also if self-monitoring, so for people who don't have a HbA1c, you may want to rely upon blood glucose monitoring, and again, depending on what that blood glucose monitoring looks like, you may decide to bring somebody in sooner if you've got that information available. And in all cases, the need to consider alternative glucose lowering therapy presents an opportunity actually to engage and do that clinical review. So use that time just as you would with any other clinical time to do the best care for people and the best holistic care for people that we can do at this time. So the first line of defence is going back and revisiting with things like education and weight management services. So structured education, if people haven't been on this is going to be a really good opportunity for somebody to engage with their diabetes care and do the best that they can in a holistic way, and their self-management can improve. Also weight management services. I appreciate the weight management services in Leeds at the moment in a bit of a state of flux. However, there is the NHS Digital Weight Management Service, which is a national digital offer around this. And also there is the remission program. So anybody who's been living with diabetes type 2 for less than 5 years may be eligible for this program. And that would be a really good thing to discuss with people. However, it's not for everybody, but these are things to revisit with that aren't necessarily medications, but that are really important in diabetes care. So as I said, we're going to review the response to GLP-1s, and this is just a summary to show you, again, remind you what the NICE guidance says around initiating GLP-1s. And this is a summary of what we've already said about selecting alternative glucose lowering therapy when GLP-1s are unavailable or where there's no beneficial metabolic response to GLP-1s. So I would suggest that you go to the national guidance and review this algorithm. It talks you through what you need to be thinking about with regards to different therapies at different HbA1c levels and different clinical circumstances. And again, this is just a quick reference guide for oral glycemic agents. This comes from the London guidance and is included in the national guidance that's been provided. And it just kind of refreshes your memory about the different medications that are available for treatment of diabetes and for which cohorts of patients they might be best for, and which people you need to just be a little bit cautious with. And again, this is also included in the national guidance, just a real summary there of the different classes of medications, oral medications, when best to use and when you might want to be a bit more cautious. Again, just a different way of showing the same thing. Also shows you roughly how much it's likely to drop your HbA1c by, some much more efficacious than others. When is insulin required? So where insulin therapy is clinically indicated, clinicians are advised to initiate in accordance to the NICE NG28 guidelines. Obviously in Leeds, you may wish to refer the person through to Leeds Community Healthcare if you feel that your skill set is not able to initiate insulin competently and confidently. Some people in practice will be very comfortable with initiating insulin, and this is really to kind of remind people that the choice of insulin should take into account those individual characteristics and clinical needs of the person living with type 2 diabetes. And where possible, we're going to try to utilise the full range of insulins and devices available, because there is risk of further impacting the supply chain if we just use one product, our favourite product maybe. And so we're trying to spread the love across products. At the moment, we've done some research to look into which products within the insulins will enable a decent size uplift in demand, and the ones that we're recommending are Toujeo, which is a U300 basal insulin, so that we would recommend for use. Humulin M3 for a mixed option, and this has an uplift available, and also Humulin I is an intermediate acting insulin, does have a partial uplift available for that as well, which people might be more familiar with. And obviously, if there's any concern about how you would start this or titrate, the summary product characteristics contain some information, but also if you're not competent or confident, please get in contact with the specialist services available for support through advice and guidance, or likewise through a referral. We are a bit concerned about counterfeit products during this time, as people get upset that their usual GLP-1 is not available. People have been seeking products through the internet, and we cannot guarantee that these are genuine products, and there are some concerns that actually some of the GLP-1s that are being provided are not GLP-1s. They're either other products or inert products that aren't going to get any response for that person. So we try to discourage people from seeking their own supply on the internet if possible. And once GLP-1 therapy, when the period of national shortages has passed, we would hope that we would be able to reinitiate. And so we need to try to keep a track of these people as best as possible and keep reviewing people. Obviously, people will have at least an annual review, if not more frequently. And we would recommend that actually during this period of national shortage, that we try to review people more frequently and make sure that we can recommence. We know that there is a product in the pipeline that's coming very shortly. It's called Tirzepatide, or its brand name Mounjaro, and we're hoping that by the end of the year this will be available to people. And we'll know a little bit more about the access criteria for this medication, and this will be something that will be in the same device as the dulaglutide or Trulicity currently. It's a product by Lilly. So we're looking forward to understanding where that's going to fit in and hopefully help us with this period of shortage.